I'm Jonathan Feit, co-founder and chief executive of Beyond Lucid Technologies, and frankly I've been inspired over the last few months by the proliferation of podcasts about fire and EMS, including aspects of our practice and industry that don't get nearly the attention they deserve, like post-traumatic stress. I've also watched as industry leaders like Josh Watts of MedTrust in South Carolina and Florida have chosen to speak directly to the markets that they serve, emphasizing their commitment and how they fulfill their mission. Many people still think of Beyond Lucid Technologies as an ePCR company, and that's fine. It's where we began, and the purpose all along was to ensure that we helped our partner clients collect good, accurate, complete data quickly and share it across their ecosystems. Because if you don't have good data to share to begin with, then you can't maximize your clinical performance, your agency's efficiency, and your financial management, including the ability to innovate. As CEO of the only EMS documentation technology company founded by two non-clinician MBAs, quite frankly, there's some pressure on us to demonstrate that better is possible, particularly at a time when it's never been more crucial to convert data to information and use the insights gained to run EMS and fire agencies at every level efficiently, to connect with hospitals in real time, and to care for patients, particularly those who are chronically ill or chronically addicted.
Imagine for a minute that lots of EMS agencies, dozens or even hundreds, transport patients to our country's hospital systems. In the Denver area, the big three, so to speak, are Centura Health, UC Health, that's the University of Colorado, and Health One. And into each of these go fire and EMS agencies all day long. They bring in chronic care patients with CHF and COPD and advanced diabetes, patients who were injured at home, at work, in the car, or with their kids, patients who have been recently discharged from the hospital and need to come back, or who have severed limbs or broken brains, or who have put things into their bodies that don't belong there and are making them ever sicker. Your crews on the line save their lives and administer medications, including naloxone, but don't necessarily know whether the decisions that they made in the field, sometimes in seconds, had the effects that they hoped. You don't get that information back seamlessly today. But what if you could? What if you could get that information instantly and you didn't need to build anything to do so? What if the hospital could sift through every run on which a particular patient was transported, but even by different EMS or fire agencies, to see a pattern of engagement that previously got lost every time the patient left the ambulance and fell off the grid, so to speak? What if we could avoid patients becoming what Dr. Marshall Isaacs, medical director of the Dallas Fire Rescue Department, has called, quote-unquote, prime numbers? That is, patients that get lost every time they leave the EMS system, but we know they're seeking and obtaining health care. What if public health agencies and hospitals could see how your patients are entering the hospital, even if they've been treated and transported by one agency and then another? For example, in San Francisco, where there are 3 911 services, and all of them might transport the same patient, even the same day, and none of them would have an idea that the other had done so. What if we could instantly close that gap and never lose track of a pre-hospital patient ever again? What if EMS data could feed health information exchanges cleanly and verifiably so that hospitals, public health services, and EMS and fire agencies could see information about patients evolve over time? Let's go back to the idea that on the hospital side, you are receiving patients from various EMS agencies, each of which is doing its darndest to save those patients' lives, make them healthier, stabilize them, ensure that information about their health history is captured and conveyed, sometimes as quickly as in 30 seconds during a quiet period when they arrive in the emergency department. All of these things we know fire and EMS agencies do every day. And just to be clear, when I say EMS, I mean fire, ground, ALS and BLS, air, critical care, ground, again, both ground and air, interfacility transports, private medical transport providers, municipal third services, and every flavor of community paramedicine that is spreading across our great country. Imagine if a hospital could instantaneously hit one or more filters on a screen that shows every one of those incoming calls to its facility, or even into the broader health network of which it's a part. For example, every UC health facility, every Centura health facility, every Kaiser facility, every Allegheny Health Network facility for that matter. Or that it could look across a region, like a city, a county, a state, incoming into the facility, the network, the region, every cardiac call, every stroke, every suspected STEMI, every suspected poisoning or overdose, every trauma call of every service individually sequestered so that you could sort them and you could filter them over time, and that you could even look up individual patients as they have been moving through the healthcare system, so that each stakeholder group could see proof positive that those patients have been round-robining the system, calling upon multiple agencies for transport. At that point, we, as a pre-hospital ecosystem, get to have a conversation asking whether the patient is so sick that she or he needs help over and over and over again, truly. Or is there an issue of mental illness or chronic disease that would benefit from a different sort of engagement along the lines of community paramedicine, mobile integrated health, or whatever else we choose to call such programs? Is the patient looking for drugs? Or is the patient simply looking for a ride? If we could have those conversations, imagine how efficient we could be without having to look backwards 30, 60, 90 days. Instead, we could look back 30, 60, 90 minutes. Unlike other technologies in the market today, the difference that we have presented here is the ability to ask and answer these questions in real time without having to build anything, without getting a bill that you can't justify, and using technology that is federally standardized, that your tax dollars and mine have already paid for, and that keep in place the ePCR systems already deployed in agencies nationwide, respecting the fact that they've invested in those technologies, in training on them, in equipment, and they understand how to use them. My team at Beyond Lucid Technologies kills fax machines for a living. It's what we like to say out here in the Bay Area. San Francisco Bay Area, I should specify. And it is my job to ensure that you never have to wonder whether a fax machine and a piece of paper was a better value than technology introduced in 2019. Now, one of the first places that the MediView Beacon Pre-Hospital Health Information Exchange was deployed was in the Denver area, an extremely important center of EMS excellence, but also a region that has struggled with an onslaught of vaporware for years. Our longtime partner client in that region was the Larkspur Fire Protection District, so it seemed appropriate that Chief Stuart Mills would lead the charge again, now toward a more nuanced view of incoming data to hospitals across the region that his department serves. Chief Mills has been joined by EMS and fire services liaising with hospitals across the country, in Connecticut, Minnesota, North Dakota, Pennsylvania, Oklahoma, Texas, Arizona, the Carolinas, and yes, even here in California. At over 100 hospitals across the country, our partner clients, not only on the ePCR side, but in some cases, agencies using other ePCR systems and working with us on interoperability and data analytics, have been building and strengthening relationships across their ecosystems to provide real-time, high-quality data mining to hospitals, regulators, and fire and EMS clinical quality executives via the MediView Beacon Pre-Hospital Health Information Exchange. Instead of simply saying, in a catch-all bumper sticker phrase, that we can connect anyone with anyone and never delivering proof, I get to be specific. And all of you who know that I like telling stories know that I sometimes give far too much detail. In this time, I think it has a place. To date, we have ingested, aggregated, and converted for real-time hospital-side EHR consumption data from 9 different ePCR systems, including Zoll, Stryker Health EMS, ESO Solutions, High Plains, Medusa Medical, Water, Firehouse, Fireworks, and of course, Mediview. But what happened last week in the Denver area was a raw demonstration of what can be possible when 3 hospital systems in one day become capable of receiving incoming data from multiple fire and EMS services. In one day, the University of Colorado Health System, as you can see on screen in front of you, became able to see, review, and return outcomes, demographics, and insurance information back to incoming charts from Larkspur Fire in the southern part of Denver, Delta County Ambulance District in western Colorado, and the Lifeguard 7-bar air medical transport team based out of the University of New Mexico Hospital. They came in through one entry point. Now, it just so happens that these 3 agencies were using Mediview at the time that they completed these charts. So the hospitals did not pay a dime to receive this information. If the services had been using a different charting system, either the agency or a combination of the two would have paid a small per record fee pegged to the value of eliminating faxes entirely. Neither the hospitals nor the EMS or fire services needed to pay for custom anything. A few months ago, you may have heard some exciting news that Miller EMS, from its base near Tulsa, Oklahoma, leveraged similar pre-hospital pipes to share details about a specialty hospice transport with the North Kansas City Hospital some 300 miles away while the transport was on the way there. We were incredibly proud to partner with Miller EMS to demonstrate the value and reality of a true nationwide pre-hospital health information exchange system. Now, we have added to the granularity of the pipe, and that's the big innovation here. Not only can the data be seen on the way in, it can now be sorted, analyzed, and tracked over time, down to the medication administered, the procedure performed, and how the patient did. Data can be grouped by disease state, and hospitals, public health agencies, and even pre-hospital care providers gain a powerful real-time tool for analyzing outcomes by patient, by department, and even for performing syndromic surveillance over a region. But as exciting as it is for us to close the data gap and demonstrate that pre-hospital data can be shared with a receiving hospital in real time, what happened in Denver was a new milestone. These large hospital systems can sift through the data to generate insight about who and what is incoming, even down to the patient. They can send data back to the source ePCR, and they didn't have to build anything. The information was waiting for them to be consumed without ever needing to touch a fax. That's how networks are supposed to work. There's no question of HIPAA. HIPAA is fully complied. The data are secure, the pipes are protected on both ends, every access is logged. And beyond the technology, this is really key here, beyond the technology, sitting at the table, discussing and demonstrating this opportunity to close the gap, were Chief Stuart Mills of Larkspur Fire and Tim Nowak of Centura Health. The EMS coordinators at Health One Sky Ridge Medical Center and the University of Colorado Health EMS Center for Excellence responded to a request from Chief Mills within minutes and had their data receiving and sharing systems set up the same day. All the time, I hear people from across EMS lament that hospitals don't care what EMS has to say and that EMS don't want to provide data and so on and so forth. It's simply not true. I also hear that EMS professionals won't be bothered to fill out data on the way to the ED because either it's too much work or the chart is boring or filling out the information would take the attention away from the patient. The second bit, the attention issue, is one of software design, not of technology. And the first bit, the idea that crews won't fill out their information and hospitals don't care even if they do. I know plenty of EMS professionals who get their charts done on the way to the ED, even those who aren't using the Mediview ePCR system. And we have demonstrated in Denver and elsewhere, proof positive, that the hospitals care what EMS have to say as long as EMS is willing to give it to them quickly efficiently in a manner that they can consume. And that is now demonstrated. That a collaborative approach to sharing information across the patient handoff from pre-hospital to in-hospital is not a future pipe dream, but a present possibility. I honestly couldn't be more excited about the idea that incoming data analytics allowing hospitals to dig into disease states, specific patient dispositions, even specific patients, and to track their engagement with EMS longitudinally, over time, leveraging standards like NEMSIS and the HL7 continuity of care document has been demonstrated, is deployed, it's working, and it's building bridges between the professionals on both sides of that handoff. This little company, Beyond Lucid Technologies, is honored to keep pushing the boundaries of pre-hospital data interoperability and to be as public as we are, even sharing information with our competitors in the process. Do you want to know why? We believe that a rising tide lifts all boats. Keeping what we have innovated proprietary and owned and benefited only to our partner clients would be anathema to the mission that we aim to achieve. So we're pleased to work with you, whether you're using our ePCR or not, and we know that we won't win every EMS or fire service. That's okay. Our job is not to sell our solutions to everybody, but to have something to provide that's of value to everybody. We believe that monopolies are the enemy of innovation, that competition breeds innovation. And if we set the bar to quality and connectivity so high that our competitors in the market can't ignore it, then you get to turn to them, no matter what patient record system you're using, and say, I want to have a better relationship with my regional healthcare ecosystem as well. That's living our mission. And I wanted you to hear it directly from me. I hope to see you soon, whether you're a EMS or fire service, whether you are an ePCR or interoperability company. I hope we can find ways to collaborate, because that's what our patients and our ecosystems depend on. I hope that the next time we all get together and talk about interoperability, we won't again rehash everything that's been said and done and talk about how complicated and expensive it is, because we've demonstrated, including in Denver last week, that it's not, that it can be done, and it's being done in many states. Thank you so much. Stay safe.